Good morning. It is my pleasure to introduce Dr. Morrison Steele this morning. Dr. Steele was born and raised in Toronto, Canada by parents who immigrated from Iran and Poland. His passion for eating disorders and child psychiatry began early as his older sister completed her PhD thesis on eating disorders and is an internationally acclaimed child and family psychologist. Dr. Steele pursued undergraduate and graduate studies at the University of Toronto in psychology and neuroscience, and he was president of the Pediatrics Interest Group in medical school. He had the privilege of training under world-renowned eating disorder expert Dr. Guido Frank in residency at the University of California, San Diego. During residency, he received multiple awards for teaching and leadership, including the Gold Humanism Resident Award and Kaiser Excellence in Teaching Award. He went on to become the chief psychiatry resident at UC San Diego, and currently he's serving as the inpatient chief fellow here at UCLA. In his spare time, he enjoys classical piano and martial arts. He's a third degree black belt in karate and purple belt in Brazilian Jiu-Jitsu. This morning, he'll be giving a very illuminating talk on eating disorders. Dr. Steele?
Thank you so much, Dr. Gillis, for the very kind introduction and generous words. Hopefully, I'm audible to you guys. I'm going to share my slides now. Okay. All right. Let's see. Okay. Hopefully this looks good. So I'm really pleased to be here with you all this morning. And I'm going to be talking about some new perspectives on eating disorder, neuroscience, and treatment. I should mention also that I have no disclosures. Always wanted to say that. Okay. See here. So I'd like to start with this quote by a couple of emotion-focused therapy experts who treat eating disorders. So a central function of the eating disorder can be understood as an attempt to manage and avoid emotion. Starving numbs, binging soothes, and vomiting provides relief. As a result, full recovery from the eating disorder necessitates mastery over intense emotional experience rather than turning to symptomatic behaviors to cope with pain. Right. This is an outline of my talk. Hopefully by the end of it, this image will make a little more sense. I'm going to talk about why my motivation for studying eating disorders, some of the neuroscience, history, and treatment. I would like to give a special thanks to Dr. Guido Frank and Dr. Lisa Adler from San Diego for their mentorship, and also apologize if I'm a little sluggish today. I just got back from Switzerland late last night. I think there's about a 9-hour time difference. Okay. So starting with some statistics, as many of you probably know, eating disorders have the highest mortality rate of all mental disorders, except for maybe opioid use disorders. This is one of the reasons why I think it's particularly important that we study them. The mortality rate for anorexia is 5 times higher than the general population. And as you can see here, 40% of those with anorexia will actually die between the ages of 25 to 34. So it's extremely lethal. And then suicide being the most common non-natural cause of death, accounting for about almost half of deaths. So really serious life-threatening conditions that we need to study seriously. On a more personal note, like Dr. Gillis mentioned, my sister is my inspiration. She's a child and family psychologist. Actually, we were in Switzerland together seeing family, and she was giving a talk there to people across multiple European countries, and just published her second book on emotion-focused therapy. You can check it out on Amazon. And so she actually, one of the reasons why she went into psychology was because she lost a really close friend in high school to anorexia. And she actually did her PhD dissertation on family-based therapy for eating disorders. So hopefully I do that justice when I talk about some of the literature later. Okay, so I think it's important to touch on normal anatomy and physiology before we get into the nuances of pathology. So all of us process taste information through the taste buds, and that information is transmitted via gustatory afferent axons of the vagus, glossopharyngeal, and facial nerves up the solitary tract to the ventral posterior medial nucleus of the thalamus, and then to the gustatory cortex in the insula, and the amygdala and higher on. So the amygdala, sorry, the insula is responsible for taste perception and body image perception, interestingly. So telling you what you're tasting, okay? The amygdala is responsible for telling you whether or not this is a good or bad taste. So kind of attaching an emotional valence to that taste, okay? And then from there, the insula and amygdala will project to the striatum and the orbitofrontal cortex, okay? And then the striatum will project back to the amygdala and insula, and then also further onwards to the prefrontal cortex, okay? It's very complicated, trying my best to simplify it here, all right? And then the hypothalamus will also project to the striatum, and that is providing homeostatic input to motivate eating. So, or the opposite. So the lateral hypothalamus promotes appetite, and the ventral medial hypothalamus decreases appetite. All right, so it kind of modulates feeding behavior. So taste information from the insula and amygdala, reward value from the striatum, limbic system, and then homeostatic drives from the hypothalamus all kind of work together to motivate us to eat or not. Okay, and this is when everything's working normally. Interestingly, in anorexia, you have changes in some of these hormonal signals. So you have less leptin, more ghrelin, more cortisol, okay, among many other abnormalities I'm going to touch on shortly. And so putting it all together here, you can kind of see these two different pathways, right? You have the ventral limbic circuit that's responsible for emotional reward processing with taste and eating. And then you have the dorsal cognitive circuit that provides kind of a top-down control mechanism, okay? So to oversimplify things, in anorexia, this top-down cognitive circuitry is dominating, okay? Whereas in binging disorders, the ventral limbic circuitry is dominating, okay? So let's try to keep this image in mind moving forward as we get into the neurobiology or pathology. So in normal individuals, okay, if you are hungry and you receive something sweet, you're going to have more activation in reward parts of the brain, okay, because it's going to reinforce the behavior of eating when you're hungry, all right? Anorexia has the complete opposite effect. So you actually have less activation in the insula, all right, when an individual with anorexia is hungry and receives something sweet. So there's a distorted signal, distorted processing of that sweet stimuli, okay? And poor connectivity to the striatum, kind of the next step in the pathway. And the striatum is responsible for motivation to eat, right? Like we were saying earlier. So you have decreased or distorted hunger signal from the insula, decreased motivation to eat from the striatum, okay? And you can see that kind of reflected in this graph over here. And then you have decreased response as well, specifically in the caudate, which is associated with harm avoidance. So doubting the past, more worrying about the future, kind of this anxious state, and inhibition of initiation to actually eat. So now these individuals are with anorexia are overly concerned about something bad happening, maybe being exposed to something anxiety provoking, and they become more avoidant. So they start to see food as anxiety provoking, okay? And their processing of food is abnormal and their motivation to eat is diminished. So all of these abnormalities taken together will contribute to food avoidance. And essentially, food becomes like a conditioned fear response, and it becomes more motivating to avoid eating rather than to eat. So the reward circuitry is total opposite from normal individuals, okay? Now, so what happens before you get the rewarding stimuli? Say you're just kind of thinking about getting food, okay? So in normal individuals, if you have weight loss, you're going to have this increase in something called prediction error, which is essentially your sensitivity to reward, or dopaminergic hypersensitivity. So if I haven't eaten all day, I'm really hungry, I'm going to be particularly sensitive to food. If I'm going to be driving by Panda Express, I'm going to be like, oh my God, maybe this is me. Maybe it might be something else for you guys. I see Panda Express, I'm like, oh my God, I have to go in there and get something. I'm going to be particularly attuned to rewarding stimuli, okay? And this is going to motivate me to eat, all right? So I meet all my nutritional requirements and I can survive, all right? This happens in everyone. In anorexia, the issue is that you have individuals with these temperamental traits. They're more harm avoidant. They're more worried about something bad happening, more perfectionistic, and they're more anxious as well. And what that does is that recruits the amygdala when thinking about food. And you have this conditioned fear response. The thought of food becomes anxiety provoking. And this increase in dopaminergic hypersensitivity goes too far. And what happens is that connection from the hypothalamus to the striatum becomes reversed. Now the striatal connections to the hypothalamus are stronger and it overrides the cues to eat, okay? And so at this point, just to remind you, we're talking about the anticipation of receiving food rather than what happens after you receive the food. So on the previous slide, we were saying, if you have anorexia, you're hungry, you receive food, you're going to have less reward associated with it. It's not as rewarding, all right? And what this is talking about is before you receive the food, just the thought of eating is anxiety provoking, okay? And the system kind of restructures in such a way that you are overriding your drive to seek out food. And this leads to food avoidance, poor treatment response, and functional impairment, okay? All right. So putting that all together, hopefully this slide makes a little more sense now. All right. Anorexia starts with this conscious motivation to lose weight for whatever reason, a diet, comments from parents, gymnastics team. And you have all these physiologic changes with gut hormones, neurotransmitter changes, prediction error, dopamine, hypersensitivity. And this is this unconscious motivation to try to stimulate them to eat. But the problem is you have these anxious and harm avoidant temperamental traits. And then so this hypersensitivity, goes overboard. And then it's no longer motivating individuals to eat. It's kind of putting them in this hypervigilant state where the thought of food becomes anxiety provoking and restriction alleviates that anxiety. And so you end up in this vicious cycle here where think of food, become more anxious, restrict, lose weight, have this motivation to eat, feel more anxious, restrict, lose more weight, okay? And a lot of this has to do with this reversal of circuitry that we were talking about with the striatum overriding cues from the hypothalamus to eat, okay? Hopefully that made sense. We can always come back and I'm happy to answer questions later. That's the most complicated thing I talk about today, I promise. All right, so then in bulimia and binge eating disorder, it's the opposite, okay? So in anorexia, you have hypersensitivity before receiving food, decreased reward response after receiving food. In bulimia, you have decreased sensitivity before receiving food, and you have increased activation after receiving food, okay? So when you even just show pictures of sweets to individuals with binge eating disorder or bulimia, you have increased activation in some of these reward pathways we were looking at. As you can see here in this chart, even after they eat, they still have activation in the insula, in the putamen, okay? It's kind of like their system isn't registering the rewarding input, okay? And most individuals, after you have that sweet, you're no longer in a dopaminergic state. You feel good, your dopamine levels go back to normal. There's continued activation in bulimia and binge eating disorder that kind of will motivate these individuals to keep eating even once full. And you can kind of think about this as like an addiction model. So there's this desensitization, okay? And while after they receive food, they're still having this activation, they're still seeking out more food. Before they receive food, right, in anticipation of receiving food, they actually have decreased response, okay? So they have less dopaminergic hypersensitivity. If you think about someone with an addiction, someone with bulimia, okay, there's a higher threshold for something to be rewarding, and this is going to push them to engage in reward-seeking impulsive behavior, really to get that high, okay? And then further in bulimia, you have this, their own vicious cycle of having negative affect, binge eating, okay, having short-term relief, and then more negative affect, shame, disgust that leads to compensatory behaviors, which provide short-term relief, and then lead to more shame and disgust, poor self-concept, and this perpetuating cycle of disordered eating. Okay. ARFID is more similar to anorexia. So in these individuals, looking at insular activation after they receive sweet food, this is those with poor appetite and ARFID, and you have less activation in the insula. Okay, so kind of similar to anorexia. What's different from anorexia is that you have these three subtypes of ARFID. And this is mostly theoretical here, but the idea is that in the poor appetite subtype of ARFID, you have decreased hypothalamic and anterior insular activation, okay? In the sensory sensitivity subtype, like the really extremely picky eaters, you have more disgust sensitivity and dysfunction in the insula. And then those with specific phobia, also known as post-traumatic eating disorder, excuse me, so an individual, maybe they choked on food, they had an allergic reaction early on, and then now they're really anxious around food and they avoid it. You have increased amygdala and prefrontal cortical activation, kind of analogous to PTSD. Kind of three separate mechanisms potentially in ARFID, but overall, can be thought of as more similar to anorexia, like another restricting condition. So putting it all together here for you, all right, like we said, we have these ventral limbic reward circuitries, and then higher order top-down dorsal cognitive control circuitry. And this is whether we're talking about food, money, drugs, any type of motivating addictive behavior, okay? And really these two different processes. In anorexia restricting type, kind of similar to ARFID, you have this top-down processes dominating, all right? Too much inhibitory control. In binge purge anorexia, bulimia, binge eating disorder, you have too much domination of reward. So essentially, comparing the two, before you get the food in anorexia, you're really hypersensitive, hypervigilant, trying to avoid food, really sensitive to any change in your environment, trying to control everything. Once you get the food, it's not rewarding, okay? You don't have as much activation in the insula and other pathways. And this is thought of as like a sensitized anti-addiction model, okay? So in anorexia, too much inhibitory control, too much hypersensitivity to food or any anxiety-provoking stimuli. In bulimia, you have the opposite. You have decreased anticipatory response, a higher threshold for something to be rewarding, and then once you get that reward, you don't register it, and you keep having dopamine release, which drives you to further binge in this kind of desensitized addiction model, okay? So anorexia, too much inhibition, sensitization. Bulimia, higher threshold for something to be rewarding, impulsive behavior, desensitization, okay? So shifting gears now to the history and give you a bit of a break from the neuroscience. The first description of disordered eating kind of goes back to around 1200 AD with St. Clare of Assisi, though pictured over here, St. Catherine of Siena is one of the more well-known. Examples. So she's one of the two patron saints of Italy and doctor of the church, and she engaged in extreme holy fasting. So only surviving on water, wine, and vegetables. And this was thought of in her time as a way of sanctifying God and purifying the body, and was also referred to as like holy anorexia. Or anorexia mirabilis, like an inspired loss of appetite, which was either inspired by devotion to God or a motivation to protect oneself from potentially poison stimuli. So you develop this aversion towards sweet tastes because maybe sweet tastes in those times were more likely to contain poison. Interestingly, those with anorexia and really picky eating do have a higher disgust sensitivity, like we were saying. So these are the earliest descriptions of disordered eating. The first formal case description of anorexia was in 1689 by Dr. Richard Morrison. And then William Gull coined the term in the 1800s, anorexia nervosa, or nervous loss of appetite. And so it's worth keeping in mind that the ability to plan ahead, control impulses, and avoid harm may have once had an adaptive purpose. And Dr. Strober would point out that, you know, in much earlier times when you're in the jungle and you're trying to hide from a predator, maybe it would be adaptive to have a smaller body habitus so you can hide behind like a rock or a tree. There's some food for thought for you. And then fast forwarding, so before DSM-5, we had more individuals with eating disorder not otherwise specified if they didn't have kind of classic weight or shape concerns like you do in anorexia. And then ARFID was added in DSM-5 to extend the diagnosis of feeding disorder of infancy and childhood throughout the lifespan, and include individuals with disordered eating who didn't necessarily have weight or shape concerns. This was really important because up to a quarter of children and adolescents with eating disorders meet criteria for ARFID. Other additions include rumination disorder, pica, binge eating disorder, atypical anorexia, purging disorder, and so forth. So hopefully this kind of categorizes these disorders in an accessible way. So the disordered eating behaviors include restricting of energy intake relative to requirements, leading to significantly low body weight. I think a better way to describe that is saying less than 10th percentile or so BMI for typical anorexia in the context of age, sex, development, and health. There's binging behaviors, so eating in a discrete period of time an amount of food that is definitely larger than what most individuals would eat in a similar period of time under similar circumstances with a sense of lack of control. And so that's usually thought of as like about this behavior happening about once a week for at least 3 months. And then compensatory behaviors, recurrent inappropriate behaviors used to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, excessive exercise. So as you can see in this chart, in anorexia nervosa restricting type, you have restricting, body image distortion, low body weight. Binge purge type, you have those same things, but also either binging or compensatory behavior. In bulimia, there's binging, compensatory behavior, and body image distortion. In binge eating disorder, there's just binging. And then in ARFID, you can have restricting with or without low body weight. You can also have nutritional deficiencies, and that would meet criteria for ARFID. You don't necessarily need to have low weights as you do in anorexia. Okay, so now moving on to treatment. And this is the last section of my talk. So as you know, treatment of eating disorders is very difficult, and it requires this multi-intervention approach, really focused on psychotherapy, in particular family-based interventions, using medications, addressing comorbidities, and this is really an understudied area and something that we're still working hard to learn more about. But there is hope, and as you can see here, when individuals with anorexia, bulimia are treated, you can actually have a normalization of some of the pathophysiology we were talking about. So those hormones, neuropeptides can normalize with recovery. The inflammatory state can normalize. The lower volume of thickness, cortical thickness in anorexia, which is actually thought to be lower than most mental disorders in severe anorexia. This can normalize with weight restoration. And so can the diversity of gut microbiome. So a lot of these really concerning changes can actually get better with treatment, which is great. And really the gold standard, as I will argue, is family-based therapy. There are 5 tenets to it. So the therapist holds an agnostic view of the cause of illness. They don't purport to know why the patient has anorexia. You don't blame the parent. You don't blame the patient or genetics or something in particular in the environment. You are where you are, and you focus on that. The therapist has a non-authoritarian stance in treatment. So it's important for them to convey that they believe that the parent is their expert, is the expert on the kid, and the kid is the expert on their eating, okay? And really form this alliance in order to make any progress. Then the parents are empowered to bring about recovery, okay? Because they're the ones that are going to be eating with the kids on discharge. So it's really important to involve them in the treatment plan. The eating disorder is externalized from the patient, as we do in many other conditions. You talk about anorexia or anxiety as being separate from the patient, okay? This is the eating disorder talking. Using language like that can be helpful. And then you focus on the here and now, okay? So regardless of whatever therapeutic plan you have, what are the symptoms causing the most impairment at this moment, and how can we address them? So phase 1, out of about 20 sessions, 20 weekly sessions, phase 1 is half of those, focuses on stabilization. Parents are given responsibility for bringing about weight restoration or eliminating binging, purging, and establishing a regular pattern of eating. So you have these family meals where eating is not a choice, and a behavioral framework is used with rewards and consequences to motivate eating. And in bulimia, there's a bit more of a collaborative approach because it's more ego-dystonic than anorexia. And then phase 2, the transition phase, the responsibility over eating is gradually handed back to the adolescent. They start to serve themselves. In ARFID, you'll do more exposures to expand variety and target specific phobias related to eating. And then phase 3, you're really addressing any issues that might come up in normal adolescence and how to move forward once weight restored. Okay. So I really don't think there can be any dispute here that family-based therapy is the most effective treatment for eating disorders. And this is from a meta-analysis within the past year. It looked at 31 studies over the past 7 years and found that the only well-established treatments for anorexia and bulimia were family-based, okay? And family-based treatment having the most efficacy in ARFID. And this is really defined by having the largest proportion of studies that were randomized control trials and really the best quality of evidence. And so family-based treatment is really favored across the board here. Some experts say that actually the effect can be as high as 84% in anorexia, and even higher when you use emotion-focused strategies there too. Okay. Looking at some of the specific comparisons, so this was the first study comparing anorexia, comparing FBT with other therapies, individual therapy in anorexia and bulimia. It was done at the Maudsley Hospital. This is why it's called, often referred to as the Maudsley method. And so FBT was found to be more effective than individual supportive therapy in anorexia and bulimia after 1 year. And its competitor, I'd probably say, is adolescent-focused individual therapy. So if FBT, emotion-focused therapy don't work, adolescent-focused therapy might be your second-line option, though FBT is more effective than that too. And you can see here in this graph, those who received FBT, there were twice as many who achieved full remission compared to adolescent-focused therapy, okay? And it's not just that it's family therapy, it's this specific type of family-based therapy that was effective, because FBT was even more effective than different types of family therapy, like systemic family therapy, okay? This is probably the most recent or best meta-analysis on this topic. So, Coutier and colleagues looked at 12 randomized controlled trials and found that FBT was superior to individual treatment in anorexia and bulimia after 6 months. Not only that, but you have faster weight gain from FBT and anorexia compared to CBT. So you can see in this graph, you achieved pretty much a weight gain in half as much time with anorexia. You can see the slope of the red and blue curves were those patients who received FBT compared to CBT. So it took about twice as long to get the same amount of weight gain from CBT. Okay, so individuals can end up staying in the hospital a lot longer when you don't incorporate FBT interventions. Also in bulimia, FBT was found to be more effective than CBT or supportive therapy in randomized controlled trials. And more recently, it's actually been found to be effective for binge eating and acceptable and safe relative to other inpatient treatment options. What about pharmacology? Antidepressants are often used as first line in anorexia. And, I really don't think that that's an effective strategy because they don't restore weight better than placebo, don't prevent relapses. Now, there was some suggestion that they might improve comorbid depression, anxiety, OCD, but actually randomized controlled trials more recently say that there's no difference in placebo in terms of improving comorbid symptoms, okay? So antidepressants really don't seem to be effective for this condition. There are a couple of randomized controlled trials looking at dronabinol and D-cycloserine. There is some modest improvement in weight, but really limited studies there. So, you're left with antipsychotics, and they're considered when you have prominent anxiety, impaired insight. So those kids who say that even though they have BMI of 9, they're the fattest in the hospital. Consider antipsychotics for agitation or hyperactivity as well. So olanzapine has the strongest evidence to support weight gain in the outpatient setting, even though it's only modest. I think here the average was about 0.67 kilograms per meter squared. But this is from a meta-analysis looking at 4 randomized controlled trials. And then you have Abilify at an average dose of 3.5 milligrams can actually be more effective than olanzapine, maybe at later illness stages or in more acute care settings, in an inpatient setting. This was a retrospective review done with 100 adolescents, and there was about a 20% improvement in BMI percentile with Abilify. So, not the largest improvements, but definitely, more effective than other medications. And so you can see it's not really about it necessarily being a side effect of the antipsychotic because weight gain is less common with Abilify, though Abilify can still be more effective than olanzapine. And that's thought because it addresses that anticipatory response we talked about, that dopaminergic hypersensitivity with the partial agonism, could potentially lead to downregulation of the dopamine receptors, reduced conditioned fear response, rigidity, and body image distortion. Other antipsychotics aren't really as effective, risperidone, quetiapine. Other medications like benzos, intranasal oxytocin, hormone replacement are found to be mostly ineffective. Okay, and then in bulimia, so Prozac is the only antidepressant FDA approved for an eating disorder, and that is for bulimia. 60 milligrams a day can reduce binging and purging episodes. Lamotrigine and methylphenidate, interestingly, are considered second line, and that is to address the affective dysregulation, kind of cluster B traits, or impulsivity that you can see complicating treatment in bulimia. TCAs, MAOIs, Buspar, and Zofran are alternative options with less evidence. Binge eating disorder, similarly, stimulants can be effective, partially because there's a high comorbidity with ADHD. So Vyvanse is the other FDA-approved medication in eating disorders. FDA approved for binge eating disorder. It's considered first line. Though Topamax, Zoloft, Cymbalta can be second line. Intranasal naloxone, decrease time spent binging. Bupropion is a controversial one. So in some studies, it's found to actually lead to weight loss without seizures, but doesn't improve the binge eating in a significant fashion. Though there are more recent studies that show that the combination of bupropion and naltrexone, kind of similarly to stimulant use disorder, can actually maybe treat binge eating disorders. So they have this similar process, like we said, right? In anticipation of a rewarding stimuli, there's a higher threshold for reward. So maybe if you raise the level of dopamine, you might decrease the reward-seeking or impulsive behavior. Then chromium wasn't found to be statistically significant. Finally, with ARFID, Remeron is thought to be first line. This was studied at UC San Diego. Can increase weight gain and also target the comorbidities, so improve gastric motility, decrease nausea and vomiting. Olanzapine at low dose, like similar to other restricting disorders like anorexia, can be used to target the dopaminergic hypersensitivity in food avoidance. So can improve also anxious and depressive symptoms and aggression in these patients. And when combined with Prozac, this and family-based therapy can really lead to very impressive results. This was over about 6 months. You had a 10-kilogram weight gain in individuals with ARFID who received family-based therapy, Prozac, and olanzapine. Finally, just looking at a few case studies here, some evidence for Zoloft, Paxil, so other antidepressants in ARFID. Ativan can be used when you have patients in an acute setting who are just really anxious around mealtime at very low doses. D-cycloserine, similar to anorexia, some evidence that it can improve feeding, though there aren't many studies that have looked at this. And then finally, cyproheptadine is used often in those with eating disorders to promote weight gain, but there's a concern that because of its anti-serotonergic properties, it might actually reduce antidepressant effectiveness. So I would say use that with caution or not at all. All right, what are we doing on time here? Okay, so putting everything together, my algorithm would be as follows. You ask whether or not there is restriction. If there isn't, is there binging? If there is binging without compensatory behavior, you have binge eating disorder. Vyvanse is first line. Second, third line options would be antidepressants, Topamax. Okay. If you have binging and compensatory behavior, you have bulimia, try an antidepressant first, augment with lamictal or methylphenidate for the impulsivity. Third, fourth line would be other antidepressants. Now, in the case of body image distortion, fear of weight gain and weight loss, anorexia, using an antipsychotic would have the most evidence. So Abilify to target cognitive rigidity, poor insight, olanzapine to target dread, anxiety, agitation, and actually experts say that you can use both at very low doses in combination if needed in severe cases. And then say you have the restricting behavior without necessarily shape or weight concerns, but you also have weight loss or nutritional deficiency. So you have ARFID, Remeron is first line, and then you can consider an antidepressant, Prozac or Zoloft to address the picky eating or the anxiety, with Zyprexa being third line here. So if you can see here, when you have binging behaviors, when you have this state of a higher threshold for reward and a lack of sensitivity, it may be effective to take a medication that's going to lower that threshold and increase the baseline dopamine level, all right, like a stimulant. Whereas when you have a restricting disorder, you have this dopaminergic hypersensitivity, right, that's leading to hypervigilance and food avoidance, it may be helpful to take a medication that will help to correct that, okay, and reducing the baseline dopamine level. So you have these two different processes going on, essentially, and medications that are going to address the baseline dopamine level that might be effective for these different reasons. And then you have these temperament-based strategies as well. Dr. Wiranega has been looking at these in San Diego, and this is to really target these specific temperamental issues with motivation and taste, kind of adapting the psychotherapeutic intervention with highly structured meals, interdisciplinary approaches, using specific techniques to address anxiety and so forth. So this is really where the treatment is headed for eating disorders, is trying to be more specific, categorizing them in terms of temperament and adapting the psychotherapeutic intervention appropriately. So in conclusion, eating disorders are the most lethal mental disorders and therefore warrant special consideration. Restricting pathology, like we said, is hypersensitive, while binging pathology is desensitized. Family-based therapy is really the only well-established treatment for anorexia and bulimia. If you are going to use medications in anorexia, antipsychotics have the most evidence to promote weight gain. And that is, we think, because they serve to decrease that level of dopaminergic hypersensitivity and anxiety around eating. Whereas Prozac and Vyvanse are both FDA approved, one for bulimia, the other for binge eating, respectively. And so in these binging disorders, it may be helpful to increase that level of dopamine to address the desensitized state in addiction-like pathology to promote normal eating. And then antidepressants, especially mirtazapine, can target ARFID-related behaviors and comorbidities. I think that is all I have for you guys today, 9:45. I have a lot of references, about over 70 in the slides here, but I will stop sharing my slides and answer some questions.
Thank you so much, Dr. Steele, for such an illuminating talk on eating disorders. That was a lot of information packed into about 40 minutes. So lots of questions and opportunity to drill down a little bit further. We have some questions. So, the FBT is definitely recognized as the kind of premier therapy for eating disorders. Are there any contraindications or downside of FBT or times when patients may not benefit from FBT?
Yes, and I see Dr. Tabwenko's question there too. Okay, so I would say, it's not going to be as effective in older patients, potentially, where the family doesn't have as much of a role in reinforcing the disordered eating. It may not be as effective also in inpatient settings, just because of the acuity or structure of the treatment setting may be more difficult to get the patient to engage or to involve the family. I still think that it should be used, but maybe in those two cases, you might see less efficacy. And that's why it's important to use other interventions like emotion-focused therapy or DBT. And in terms of addressing the intergenerational nature of anxiety and eating disorders, I think that involving the family is one of the best ways to do that. And in doing so, you can get, elicit and address parents, different perspectives on eating and provide psychoeducation and so forth. Yeah, definitely, while it's not a perfect intervention, I would still say that it's the most likely to be effective.
So if we can highlight the intergenerational nature, I think the question is asking more about how FBT does that, because some parents may have undiagnosed eating disorders that they have not fully addressed. How does FBT address that? How does FBT address family involvement when there may be anxiety component in families that's being accommodated, the eating disordered behaviors that are accommodated or reinforced in families. Can you speak a little bit more about that part of it?
Sure. And really, I mean, I think that FBT is the only way to do that, because if you don't involve the family, you're not going to see the effect of the intergenerational anxiety on the patients. But I mean, really, it's sitting down with the family and seeing how that shows up at mealtime, and providing, you know, psychoeducation and coaching. I mean, it kind of depends on how the anxiety manifests and the types of statements that the parents are making around mealtime, and really providing them with education on, you know, what are better ways that you can phrase that, you know, what are things that are going to reinforce the anxiety and the avoidance around eating. So I think just really spending time observing how that anxiety comes up around mealtime, and providing psychoeducation and coaching on like what are more therapeutic ways of interacting with kids is how that would be done.
Might there be instances where families or parents need to go get their own treatment, in addition to being involved in their child's care? I ask because in trauma, we see this a lot, especially in sexual trauma, where the kid's disclosure of sexual trauma will often ignite kind of parents' history of sexual trauma that's unresolved. And so, a recommendation there is for the parent to go get their own individual treatment. Might there be room for that? And what does the literature say about that, if anything?
I'm not sure specifically what the literature says about that. I would say, like, in general, when working with parents, I think that if they do have a considerable amount of, you know, anxiety or trauma related symptoms themselves, then of course it's important to get their own individual therapy, whether you're talking about eating disorders or any other issues that the kids have. But really the focus when you're doing therapy with kids or family-based interventions is how their symptoms come into play with respect to the kids. How are they showing up and at mealtime? How are they influencing their kids? And what are ways that you can mitigate that? But of course, if the parents do have severe symptoms themselves, then definitely a recommendation would be to treat that on an individual basis, whether you're talking about eating disorders or anything else.
Yeah. We see a lot of families on the inpatient unit, particularly when the kids are on the waiting list, where the family may not believe in eating disorders. How do you address that in terms of families not believing that the significant weight loss is a problem?
Yeah, and that's, I mean, definitely you have poor insight in the kids, you have poor insight in the families. And that's why you know, in family-based therapy, going back to those core principles, it's not about necessarily what the cause is of their eating disorder, or whether or not you call it an eating disorder. It's focusing on the here and now, and what kind of problems they're having, what are the medical comorbidities and issues they're having associated with weight loss, you know, whether it's like syncope or electrolyte abnormalities, or the fact that they're ending up in the hospital. You know, these are problems that you want to address, whether or not you call it an eating disorder or you focus on the weight loss. So you try to build insight like you do in any case with mental disorders, by looking at, like, you know, is there a problem here that's affecting this kid's quality of life on a day-to-day basis? Are they suffering? You know, we don't need to call this anorexia or anything else. We just need to address the way that your child is suffering in this moment.
Yeah, it can be really tough because some families don't even see the need for kind of a higher level of care, so to speak. So that part can be really tough. There's another question about, is there literature on behavioral family therapy for ARFID?
Yes, there is. It's really only in the last few years, actually. It's definitely more limited, and relative to anorexia and bulimia, also because of the fact that ARFID is just a newer disorder itself. But in the case of ARFID, it's much more behavioral. It's much more CBT focused. And a lot of the differences you see are in that second phase of treatment. So once you're kind of transitioning control of eating back to the adolescent, it's looking at where are those specific anxieties and phobias lying. and how do you develop an exposure hierarchy to address them? Whether it's, a fear of eating solid foods or a fear of foods with specific textures or whatnot, and you'll develop an exposure hierarchy with them, and you'll use kind of CBT based interventions to address that. So I would say much more behavioral and exposure focused for ARFID.
And less, the literature sounds like it's less kind of focused on family involvement for ARFID and more kind of like the individual behavioral changes and exposures to different types of food is what you're.
There's definitely still family involvement, but as you transition control back to the patient, there's a bit more of customizing in the therapy based on what are their specific anxieties around eating. There's so much more variety and variability in ARFID, but definitely still a role for the family as well.
A question I just thought about is, does ARFID always present initially during childhood or adolescence, or can it present at some point after, someone emerges into adulthood?
It presents most commonly in childhood and adolescence. I mean, it's possible to present in adulthood. This is the condition that used to be the feeding disorder of infancy or childhood. So I would say that it's most likely to present early on in really anxious kids. But I think with any eating disorder, it's a spectrum, and it's certainly possible to present later.
Yeah. Does the literature say much about the comorbidity of autism and ARFID?
Yes, there is a comorbidity with autism and ARFID. I think the highest comorbidity is with anxiety disorders. About 50% of kids with ARFID have things like GAD, but there is a high comorbidity with neurodevelopmental disorders as well, like autism, and having that rigidity, being very concrete about certain things you might eat, certain types of textures or flavors or whatnot. So there's definitely an association there.
Okay. Thank you. Speaking of neurodevelopmental disorders, there's a question about, how we think about early intervention, and there's a sensitive period of intervening in neurodevelopmental disorders. Is the same true or important for eating disorders? Is it important to intervene early? And if so, how does this impact prognosis?
Yes, I mean, like with any mental disorder, the earlier you intervene, the better. I think the sensitive period you see with eating disorders, it's usually, around mid-adolescence. After you go through puberty, you have these hormonal changes that are actually thought to be, related to the development of things like anorexia. So, and you'll see kind of the development of the perfectionistic traits in school, and the rigidity, and then also impulsivity for the binging disorders. A lot of those types of behaviors are heightened in general in adolescence. So you have the temperamental or the personality development, the hormonal changes, and then the way those things can get converted into eating disorders around mid-adolescence after puberty. So definitely paying attention to those types of behaviors and how they may or may not affect eating would be really important around that time and getting kids into treatment.
Yeah, yeah. So you've spent a lot of time, and I know that these are both your passions, like on the neurobiology and the treatment. So want to ask some questions about that. One is that there was a slide, and I know this is a part of the literature saying that it's not effective, or it was suggesting it's not effective to use antidepressants to treat the comorbid anxiety, depression, OCD. What does the literature suggest? Does it suggest you not treat those things, that you focus on the eating disorder first? What do you use to treat comorbid depression, anxiety, OCD, and eating disorders?
So again, it's controversial. And actually I had come across a randomized control trial from the past year that I think that was the biggest study to look at this. And it did say that in anorexia, antidepressants are not better than placebo at treating comorbid anxiety symptoms. So I would say, and honestly, I think you can kind of think about that as analogous to other conditions like autism, where antidepressants don't seem to work as well to treat a lot of comorbidities. Really, I would say that the first line most effective treatment is therapy. When you try to just only address the anxiety in isolation, things like anorexia, you're not really addressing the core pathology. So, the antidepressants just don't seem to work as well. So I would say using therapy, family-based therapy, and then, low dose antipsychotics when you're hitting roadblocks and you have really severely low insights or refractory symptoms.
Is the antipsychotic going to treat the comorbidities though, or what's kind of the approach from the clinical perspective?
It would. It would, because a lot of those comorbidities, I mean, specifically in ARFID, like I was saying, there's evidence the antipsychotics can address some of the comorbidities there. But the idea is that the anxiety, the harm avoidance, a lot of the comorbidities you see, the impulsivity is related to the dopaminergic state. So in anorexia, whether that being a hypersensitive dopamine state that's leading to anxiety and hypervigilance, or in bulimia or binging pathologies where you have a desensitized state, a low dopamine state before receiving a rewarding stimulus, which is driving impulsive behavior. If you correct that state from a dopaminergic standpoint, you should then have improvement of the other symptoms and comorbidities associated with it. So it's the idea, it's a different mechanism pathologically than the anxiety that you see in an anxiety disorder.
Got it. We're at 9:59, so I want to leave a minute for you to give a final takeaway. What should people take away from your talk today?
That eating disorders are really important to study further. The most important thing is involving the family and really being judicious about the use of medication. But that there is certainly hope for the future, I would say. Yeah, I mean, that's what I would say.
All right. We want to thank you for this illuminating talk today and also thank our audience for attending and participating.
Thank you all so much.